Gender-based pathologies in exercise and sport. Some of the content within this lecture can be found in chapters 17, 23, and 27. Please note in this lecture we are only going to talk about the definition and common signs and symptoms of these conditions. We will discuss some treatment, but pretty much all of these conditions should be referred to a physician, as this is out of the scope of practice for most coaches, athletic trainers, personal trainers, chiropractors, and physical and occupational therapists. However, your patients might discuss these conditions with you or ask for advice, or these conditions may complicate treatments for other conditions, and therefore this information is included within the content of this course. Please be warned, some of the pictures in this lecture include images of male and female reproductive organs. The pictures were chosen to demonstrate conditions. I realize that some of these conditions might be difficult to talk about or make some people uncomfortable. The intention of this lecture is to make students aware of different gender-based pathologies. As allied healthcare providers, many patients ask questions to the first person they trust, so it is important that each of us understand these different types of injuries in a professional manner. We will first start with conditions which can occur to the male athlete. These conditions include genital injuries, scrotal masses, testicular cancer, and gynecomastia. Male genital injuries can occur in two general regions, either the testicular or penile region of the body. Testicular injuries are commonly a result of direct trauma. This direct trauma to the testicular region can cause a torsion of the spermatic cord, epididymitis, cryptorchidism. Penile injuries are also the most commonly the result of direct trauma injuries. Frostbite and traumatic irritation are two of the most common types of penile injuries. In men and boys, the testicles hang outside of the body in a pouch of skin called the scrotum. Because of their location, many types of accidents can cause testicular injuries. Blunt trauma or strike causes 75% of testicular injuries. Examples include getting kicked, getting hit by a baseball or other sports apparel, motorcycle accidents, and bicycle accidents. Other mishaps can cut or pierce the scrotum and injure the testes. These include animal bites, bullet wounds, and accidents with machinery. As many men and boys know all too well, a testicular injury typically causes substantial pain in the scrotum. There is sometimes pain in the abdomen as well. Other symptoms can include nausea, especially common with testicular torsion, bruising or discoloration of the scrotum, swelling of the scrotum, blood in the urine, difficulty urinating, fever, and anxiety is also a common sign and symptoms, as these are vital structures and patients might be embarrassed about having to show this area or this type of injury to a medical professional or even talk about it. But they are very important injuries to have assessed, and left untreated may result in pretty severe consequences. It is important to determine if the injury is truly a contusion. When an accident injures blood vessels in the testicle, it can cause a contusion, which may involve bleeding or bruising, or whether this injury is something more serious. Other similarly related conditions or differential diagnosis include testicular torsion or fracture of the testicle or epididymitis. A testicular torsion will result in pain that lasts longer than 12 to 24 hours, and a fracture will result in a mass in the testicles. If a mass is found, a physician will place a strong light behind the testicles to see whether light can pass through it. This is called transillumination. A testicular tumor is too solid for light to pass through and therefore will not transilluminate. Light will pass through the mass or swelling caused by a hydrocele. The other testicle will be felt and examined to make sure that it does not contain any lumps, masses, or other abnormalities. Epididymitis is an inflammation of the epididymis, the tube behind the testes that carries sperm. This inflammation can cause a tender lump or mass behind the testicle. Testicular torsion occurs when the testicle rotates, twisting the spermatic cord that brings blood to the scrotum. This reduced blood flow can cause sudden and often severe pain and swelling. Testicular torsion should be considered whenever there is scrotal pain and swelling. Testicular torsion is most common between the ages of 12 and 16, but can occur at any age, even before birth. We are more likely to see this condition in boys who have not quite undergone puberty or are just going through puberty, but it can occur in any age. Signs and symptoms of testicular torsion include sudden severe pain in the scrotum. Signs and symptoms of testicular torsion include sudden severe pain in the scrotum, swelling of the scrotum, abdominal pain, nausea and vomiting, and a testicle that is positioned higher than normal or at an unusual angle. Remember, one of the testicles, usually the left, hangs lower and is slightly smaller than the right in normal conditions. Painful urination and fever. Young boys who have testicular torsion typically wake up due to scrotal pain in the middle of the night or in the morning. Testicular torsion usually requires emergency surgery. If treated quickly, the testicle can usually be saved. But when blood flow has been cut off for too long, a testicle might become so badly damaged that it has to be removed. Surgery is often required to correct testicular torsion. In some cases, the doctor may be able to untwist the testicle by pushing on the scrotum, which is called manual detorsion, but you will still need surgery to prevent torsion from occurring again. Elevation of the scrotum often relieves pain in epididymitis, but increases pain in torsion. Epididymitis is an inflammation of the coiled tube or epididymis at the back of the testes that stores and carries sperm. Males of any age can get epididymitis. Epididymitis is most often caused by bacterial infections, including sexually transmitted infections, or STIs, such as gonorrhea or chlamydia. In patients under the age of 35, epididymitis is most often the result of an infection with chlamydia. In patients over the age of 35, the infection is most frequently caused by an E. coli infection. Signs and symptoms of epididymitis may include a swollen red or warm scrotum, testicle pain and tenderness, usually on one side, painful urination or an urgent or frequent need to urinate, discharge from the penis, painful intercourse or ejaculation, a lump on the testicle, enlarged lymph nodes in the groin, pain or discomfort in the lower abdomen or pelvic area, blood in the semen, and less commonly fever. The treatment for epididymitis is typically antibiotics, usually from the fluoroquinine class of drug. Cryptociticism is the absence of one or both testes from the scrotum. It is the most common birth defect of the male genitals. About 3% of full-term and about 30% of premature infant boys are born with at least one undescended testes. However, about 80% of crypticid testes descend by the first year of life, the majority within 3 months, making the true incidence of cryptociticism around 1% overall. Cryptociticism may develop after infancy, sometimes as late as young adulthood, but that is exceptional. The primary management for cryptociticism is watchful waiting, due to the likelihood of self-resolution. Where this fails, a surgery called orchoplexy is effective if inguinal testes have not descended after 4 to 6 months. Orchoplexy is a surgery to move an undescended or crypticid testicle into the scrotum and permanently fix it there. Orchoplexy typically describes the surgery used to resolve testicular torsions as well. Surgical repair is necessary as prolonged conditions pose a slightly increased risk of testicular cancer and decreased fertility. Anorchia is the absence of both testes at birth. The embryo develops early sex organs in the first several weeks after the egg is fertilized. If early testes do not develop in males before 8 weeks into the pregnancy, the baby will have female genitals. If the testes disappear between 8 and 10 weeks, the baby will be born with ambiguous genitalia. This means that the child will have the parts of both male and female genitals. However, if the testes disappear between 12 and 14 weeks, the baby will have normal male genitals, a penis and a scrotum, but no testes. This is known as congenital anorchia, or the vanishing testes syndrome. The cause is unknown. Genetic factors may be involved in some cases. This condition should not be confused with bilateral undescended testes, in which the testes are located in the abdomen or groin. Direct trauma to the penis is usually from a saddle injury or a direct blow to the pubis. With enough trauma, vascular injuries, and potential for impotency can result. Direct trauma can lead to partial or complete urethral rupture, usually requiring a more forceful injury than that with sporting activities. However, this is common in rodeo. Symptoms include immediate pain, swelling, and perineal ecchymosis. Direct trauma to an erect penis can cause fracture to the tunica albuginea. The area of the fracture becomes swollen in ecchymosis with the penis bent to the affected side. Both of these injuries are urological emergencies. Occasionally, men who run, ski, or ride motorcycles can experience frostbite on the tip of the penis. Wearing proper clothing can help prevent this from occurring. If frostbite does occur, gently rewarm the area and look for blistering. Pudendal nerve irritation is due to pressure, usually from a bicycle seat, being created along the pathway of the pudendal nerve that creates a very uncomfortable symptoms. These symptoms include pain referred to the perineum, pelvic floor, genitals, and internally in women, pain to the genitals, perineum, and the back passage in men, pain and tightness into the back of the hips, posterior pelvic pain or pubic pain, pelvic or perineal pain that is worse with sitting or when stressed, pain that is worse in tight clothing. Pudendal nerve irritation can result in priapism, which is a prolonged erection, or ischemic neuropathy, which is a lack of oxygen to the pudendal nerve. Scrotal masses are fairly benign conditions unless they are causing pain or rapidly expanding. A spermatocelli and hydrocelles are cystic masses. Spermatocells are cysts within the epididymis or adjacent to the testicles caused by extravasation of sperm from trauma or infection. Extravasation is the process by which any liquid accidentally leaks into surrounding tissue. Hydrocells are cysts surrounding the epididymis or testicle, usually filled with fluid from the tunica vaginalis. Hydrocells are a collection of blood in the tunica vaginalis. They do not transilluminate, unlike spermatocells or hydrocells. If the mass is rapidly expanding, then surgical management may be warranted. A varicocele is an enlargement of the veins within the loose bag of the skin that holds your testicles, or the scrotum. A varicocele is similar to varicose veins that occur in the leg. Varicoceles are a common cause of low sperm production and decreased sperm quality, which can cause infertility. However, not all varicoceles affect sperm production. Varicoceles can also cause testicles to fail to develop normally or to shrink. Most varicoceles develop over time. Fortunately, most varicoceles are easy to diagnose and many don't need treatment. If a varicocele causes symptoms, it often can be repaired surgically. A hematocele is a collection of blood within the body cavity. This term is generally used to refer to the collection of blood within the tunica vaginalis around the testicle. Hematoceles are often more painful than is a hydrocele. Testicular cancer typically develops in one or both testicles in young men, but can occur in older men as well. It is a highly treatable and usually curable type of cancer. Testicular cancer is typically a firm, non-tender mass in the testicle. It does not transilluminate. An ultrasound may be performed to determine if the mass is solid or full of fluid. A cancer tumor is most frequently a solid mass. It is recommended that males start performing monthly testicular self-examinations, or TSEs, starting around age 14 or 15 years old. The statistics from the American Cancer Society's estimates for testicular cancer in the United States for 2016 are: about 8,720 new cases of testicular cancer will be diagnosed. About 380 men will die from testicular cancer. The incident rate of testicular cancer has been increasing in the United States and many other countries for several decades. Testicular cancer is not common. About 1 out of every 263 males will develop testicular cancer at some point in his life. The average age at the time of diagnosis for testicular cancer is about 33 years of age. This is largely a disease of young men and middle-aged men, but about 7% of cases occur in children and teens, and about 7% occur in men over the age of 55. Because testicular cancer usually can be treated successfully, a man's lifetime risk from dying from this cancer is low, about 1 in 5,000. Gynecomastia is a swelling of the breast tissue in boys or men. This is caused by imbalances in the hormones estrogen and testosterone. Gynecomastia can often affect one or both breasts, sometimes unevenly. Newborns, boys going through puberty, and older men may develop gynecomastia as a result of normal changes in hormone levels, although other causes can exist. Generally, gynecomastia is not a serious problem, but it can be tough to cope with this condition. Men and boys with gynecomastia sometimes have pain in their breast and may feel embarrassed by the condition. Gynecomastia may go away on its own. Treatment that begins within 1 year will usually reverse this condition. If the condition persists, medication or surgery may help. Gynecomastia is triggered by a decrease in the amount of hormone testosterone compared with estrogen. The cause of this decrease can be conditions that block the effects of or reduce testosterone, or a condition that increases your estrogen level. Several things can upset the hormone balance, including the following: natural hormonal changes, medications, street drugs and alcohol, health conditions, some products including tea tree, lavender, or soy, possibly due to these substances' weak estrogenic activity. Most people think of estrogen as an exclusively female hormone, but men also produce it, although normally in small quantities. However, male estrogen levels that are too high or out of balance with testosterone levels can cause gynecomastia. Gynecomastia in infants: more than half of all male infants are born with enlarged breasts due to the effects of their mother's estrogen. Generally, the swollen breast tissue goes away within 2 to 3 weeks after birth. Gynecomastia can occur during puberty. Gynecomastia caused by hormone changes during puberty is relatively common. In most cases, the swollen breast tissue will go away without treatment within 6 months to 2 years. Gynecomastia can also occur in men. The prevalence of gynecomastia peaks between ages 50 and 80. At least 1 in 4 men in this age group are affected. Female-specific conditions include breast injuries and disorders, pregnancy, menstrual cycle irregularities, and the female athlete triad. Common breast injuries and disorders include blunt trauma, which will result in ecchymosis, swelling, and a hematoma; mastitis, which is a skin infection which can be cured most often with antibiotics; mastalgia, which is breast pain, which helps if you have a supportive bra. Diet and oral contraceptive pills can also help with the pain; nipple discharge, which may be pathological if it is spontaneous; and breast mass. Breast cancer starts when cells in the breast begin to grow out of control. These cells usually form a tumor that can often be seen on an X-ray or felt as a lump. The tumor is malignant or cancerous if the cells can invade surrounding tissues and spread or metastasize to distant areas of the body. Breast cancer occurs almost entirely in women, but men can get this too. Breast cancers can start from different parts of the breast. Most breast cancers begin in the ducts that carry milk to the nipple, or ductal cancers. Some start in the glands that make breast milk, or lobular cancers. There are also other types of breast cancers that are less common. Although many types of breast cancer can cause a lump in the breast, not all do. There are other symptoms of breast cancer that you should watch out for and report to healthcare providers if you find. It is also important to understand that most breast lumps are not cancer, they are benign. Benign breast tumors are abnormal growths, but they do not spread outside of the breast and are not life-threatening. But some benign breast lumps can increase a woman's risk of getting breast cancer. Any breast lump or change needs to be checked by a healthcare provider to determine whether it is benign or cancer and whether it might impact your future cancer risk. Breast cancer is the most common cancer among American women except for skin cancer. About 1 in 8 or 12% of all women in the United States will develop invasive breast cancer during their lifetime. The American Cancer Society estimates that there will be about 246,660 new cases of invasive breast cancer that will be diagnosed in 2016. About 61,000 new cases of carcinoma in situ, or CIS, will be diagnosed. CIS is non-invasive and is the earliest form of breast cancer. About 40,450 women will die from breast cancer this year. The incidence of breast cancer is diagnosed by self-breast exams, mammograms, and possibly fine needle aspiration to determine the type of tumor present. Screening should include monthly self-breast exams starting at age 18 or possibly even younger, annual clinical breast exams from age 18, and mammograms every 2 years from age 40 to 50 and then 1 time a year after 50. However, mammograms may be used for younger patients who are at a really high risk for breast cancer. During pregnancy, there are many physical changes to a woman's body over a 9-month period. There are changes to the cardiovascular system, the musculoskeletal system, respiratory system, and weight gain and nutritional demand change. When a woman gets pregnant, there becomes an increase in blood volume, with a nearly 50% increase in blood volume by the end of pregnancy. Plasma volume also increases, as does the amount of red blood cells. Pregnant females can suffer from dilutional anemia until 32 weeks into pregnancy. With the increase in red blood cells, there is a greater oxygen carrying capacity. increased cardiac output and stroke volume. Pregnant women have an increase in pulse rate, decreased blood pressure, and decreased venous tone. The respiratory changes that occur during pregnancy help to facilitate gas exchange between the mother and the fetus through the placenta. There is an increased ventilation, decreased carbon dioxide levels, and increased pH. These changes help prevent fetal acidosis. Most pregnant mothers complain about feeling short of breath, but in all reality, there is an adequate oxygen supply. The increase on blood volume has an effect on the amount of oxygen that can be carried to vital body structures. Pregnant women should avoid prolonged anaerobic exercise. Under prolonged exercise, maternal blood sugar may decrease, creating maternal hypoxia and acidosis. When the mother has this condition, it results in fetal hypoxia and acidosis as well. A pregnant female needs to consume extra calories to meet the demands of both pregnancy and an exercise regimen. There are musculoskeletal changes associated with pregnancy, postural changes as the center of gravity changes during pregnancy. This affects gait and balance. As the pregnancy progresses, the center of gravity moves from the center of the core between the pelvis to a little more forward position, causing a forward shift in the center of gravity. There are also associated changes in laxity due to the release of progesterone. Progesterone releases ligaments and allows for the baby to pass through the birth canal. Similarly, relaxin is another chemical released to increase joint laxity and pelvic laxity, allowing for the baby to pass through the birth canal. The risk for falling and sprains is much higher in pregnant females due to these chemical mediators released associated with pregnancy. Most people associate weight gain and nutritional changes with pregnancy. Although it is commonly said that pregnant women are eating for two, we have to remember that she isn't eating for two adults. The average weight gain during pregnancy is somewhere between 25 and 30 pounds. 40% comes from the fetus, amniotic fluid, and placenta. If you increase your baseline caloric need by just 300 kilocalories per day, it is more than sufficient to provide for the caloric needs of the developing baby. Dehydration can cause nausea, vomiting, ketosis, and hypothermia. Exercise during pregnancy is recommended. Exercise programs need to be individualized, but it is recommended that pregnant females should complete 30 minutes or more of moderate exercise every day. The primary goal with exercise during pregnancy is safety. The physical benefits associated with these exercises during pregnancy include maternal fitness, controlling weight gain, decreased back pain, increased sleep and energy, decreased water retention, decreased varicose veins, shortened labor and decreased complications, and rapid postpartum recovery. Psychological benefits associated with exercise during pregnancy include improved self-image and mental outlook, improved sense of control, and relief of tension and stress. Exercise is contraindicated for some conditions during pregnancy. These conditions include pregnancy-induced hypertension, premature rupture of membranes, history of preterm labor, incomplete cervix, persistent second or third trimester bleeding, IUGR, which is intrauterine growth restriction. This refers to a condition in which the unborn baby is smaller than it should be because it's not growing at a normal rate inside the womb. Exercise may be restricted by a physician or should be monitored if the following conditions are present. Multiple gestations, which means there's more than one baby. This includes twins, triplets, or more. A history of miscarriage, especially greater than 1 year. Breech in the third trimester, or a history of precipitous or early labor. Regular activity of at least 3 times a week is preferred to intermittent activity. During the first trimester, a woman should try to augment heat dissipation with proper hydration and appropriate clothing and environmental surroundings. Hypothermia in the first trimester has been associated with neural tube defects. Abdominal trauma should be avoided, and morphological changes during pregnancy may change posture and balance. Pregnancy leads to a decreased maternal oxygen availability for aerobic activity. Exercise intensity should be modified to maternal symptoms, meaning women can experience fatigue but avoid exhaustion. Rule of thumb would be to target about 65 to 85% of your maximum heart rate. Lying in the supine position can decrease the cardiac output due to the increased pressure on the inferior vena cava from the uterus. This becomes more apparent as the uterus grows in size. Normal pregnancy requires an additional 300 kilocalories per day to maintain metabolic hemostasis. Women who exercise should ensure an adequate diet and proper nutrition to accommodate their activity. All women should be on a multivitamin with iron and folate. Most women should have a calcium supplement as well. A physically active female tends to have a higher degree of menstrual disorders compared to non-physically active females. In the United States, the average age for a girl to get her first period is around age 12. This does not mean that all girls start at the same age. A girl can start her period any time between the ages of 8 and 15, although there are reports of earlier period startage for younger girls. Most of the time, the first period starts about 2 years after breasts first start to develop. If a girl has not had her first period by the age of 15, or if it has been more than 2 to 3 years since breast growth started, she should see a doctor. Females are considered to have a delayed menarche if they have not started before age 16. It is not uncommon for women to have irregular menstrual cycles as well. A cycle of less than 25 days is considered a short cycle. A cycle of more than 35 days is considered a long cycle. If a woman has less than 3 cycles per year and she is not on any oral contraceptive medication, then it is determined to be an absence of a period or no cycle periods. Menstruation is a woman's monthly bleeding. When you menstruate, your body sheds the lining of the uterus or the womb. Menstrual blood flows from the uterus through the small opening in the cervix and passes out of the body through the vagina. Most menstrual periods last from 3 to 5 days. In the first half of the cycle, levels of estrogen or the female hormone start to rise. Estrogen plays an important role in keeping you healthy, especially by helping you to build strong bones and to keep them strong as you get older. Estrogen also makes the lining of the uterus or the womb grow and thicken. This lining of the womb is the place that will nourish the embryo if a pregnancy occurs. At the same time the lining of the womb is growing, an egg or ovum in one of the ovaries is starting to mature. At about day 14 of an average 28-day cycle, the egg leaves the ovary. This is called ovulation. After the egg has left the ovary, it travels through the fallopian tube to the uterus. Hormone levels rise and help prepare the uterine lining for pregnancy. A woman is most likely to get pregnant during the 3 days before or on the day of ovulation. Keep in mind, women with cycles that are shorter or longer than average may ovulate before or after day 14. A woman becomes pregnant if the egg is fertilized by a man's sperm cell and attaches to the uterine wall. If the egg is not fertilized, it will break apart. Then hormone levels drop and the thickened lining of the uterus is shed during the menstrual period. Women can have a range of problems with their period, including pain, heavy bleeding, and skipped periods. Amenorrhea is the lack of a menstrual period. Oligomenorrhea is the term that is used to describe the absence of a period in young women who have not started menstruating by age 15, women and girls who have not had a period within 90 days even though they haven't been menstruating for long, and the causes can include pregnancy, breastfeeding, extreme weight loss, eating disorders, excessive exercising, stress, and serious medical conditions in need of treatment. Dysmenorrhea is painful periods, including severe cramps. Menstrual cramps in teens are caused by too much of a chemical called prostaglandin. Most teens with dysmenorrhea do not have a serious disease, although cramps can be severe. In older women, the pain is sometimes caused by a disease or condition such as uterine fibroids or endometriosis. For some women, using a heating pad or taking a warm bath helps ease their cramps. Some over-the-counter pain medications can also help with these symptoms. They include ibuprofen, ketoprofen, and naproxen. Abnormal uterine bleeding or vaginal bleeding that is different from normal menstrual periods includes bleeding in between periods, bleeding after sex, spotting any time in the menstrual cycle, bleeding heavier or for more days than normal, bleeding after menopause. Abnormal bleeding can have many causes, and your doctor may start by checking for problems that are most common in your age group. Some of them are not serious and are easy to treat. Others can be more serious. Treatment for abnormal bleeding depends on the cause. The risks for having menstrual cycle irregularities include young age, being extremely active, especially if you run, cycle, dance, or swim at high intensities, intensity of exercise, mileage or duration of exercise, history of irregular menses, prepubertal training, delayed menarche, and inadequate nutrition. This is usually in protein or calorie intake. The female athlete triad is a syndrome of 3 interrelated conditions that exist in a continuum of severity, including Energy deficiency with or without an eating disorder. An energy deficiency is an imbalance between the amount of energy consumed and the amount of energy expended during exercise. The primary cause for the female athlete triad is energy deficiency. Often this can involve a conscious restriction of food intake, problems with body image, and a high drive for thinness. Sometimes these conditions can lead to disordered eating or a more serious eating problem, an eating disorder like anorexia and bulimia. Menstrual disturbances or amenorrhea. The most serious menstrual problem associated with the triad is amenorrhea. This is defined as no menstrual period for 3 months or more. However, athletes who have irregular menstrual cycles are also susceptible to the effects of the triad. Bone loss or osteoporosis. Women with the triad are at high risk for low bone mass leading to weakened bones called osteoporosis in its most severe form. This type of bone loss can cause an increase in risk of fracture, including stress fracture. So who's at risk for developing the female athlete triad? Sports with subjective scoring such as dance, figure skating, and gymnastics. Endurance sports favoring low body weight like distance running, cross-country skiing, and cycling. Also sports involving body-revealing contoured clothing for competitions such as volleyball, swimming and diving, running, and wrestling. Sports with weight categories such as horse racing, rowing, martial arts, and wrestling. Also sports which emphasize prepubertal body habitus favors success. This includes gymnastics, diving, and figure skating. There is a difference between an eating disorder and disordered eating. Disordered eating is not eating consistently. This could include portion size, caloric intake, the time of meals, or the frequency of eating. I know some days it can be hard for me to get a meal at lunch sometimes, and therefore I skip meals. This qualifies as disordered eating. I do not know many college students who do not exhibit disordered eating at one point or another. An eating disorder, on the other hand, is a psychological condition. This results in regulated eating behaviors, usually due to control issues. There may be body image issues, including body dysmorphia, which is a distortion in the image that the person sees in the mirror and what other people perceive. Many eating disorders are related to feelings of loss of control. This table is a comparison of bulimia nervosa and anorexia nervosa. Bulimia nervosa has certain factors. Weight will be normal for the age and height of the individual. Fluctuations in weight loss are common. It is most commonly associated with females in their teens and 20s and also seen commonly in male wrestlers. Their body image is distorted for their body shape and weight. They have recurrent binge eating habits followed by fasting. Purging may or may not occur. Laxatives, diuretics, and self-induced vomiting may be used. The self-esteem is low, depression is common, and obsessive-compulsive behavior is also associated. The menses will be irregular. For anorexia, the following factors are more associated. For weight, it is typically 15% below what is expected. The weight loss is more gradual. It is more common for anorexia to occur in females and teens. However, the predominance of male association is now becoming more prominent. The body image is very distorted. The person feels fat even when they're emaciated, which means their skin and bones are showing. Their eating habits may be near starvation. Purging is not common. The self-esteem again is low. Obsessive-compulsive behaviors for perfection are often seen. As far as menses is concerned, amenorrhea or an absence of menstrual cycle is common. Eating disorders may not be just classified as anorexia or bulimia. There is also an eating disorder that is not otherwise specified. This eating disorder, NOS, meets the criteria for anorexia with normal menses. It can also meet the criteria for anorexia nervosa, but the person will have a normal body weight. They may also meet the criteria for bulimia nervosa, but have fewer binging and purging episodes. They may also have compensatory episodes even after a small intake, so they may binge and purge even after eating small amounts of food. They may also repeatedly chew and spit out food but not swallow large amounts of food, which is common in wrestlers. Binge eating disorder may also occur. These statistics in the lower right-hand corner are slightly terrifying. 40% of 9-year-old girls have dieted. 80% of 13-year-old girls have dieted. So dieting is occurring in very, very young populations. So are these eating disorders. Whether a person gains, loses, or maintains weight is determined by the intake of food or the energy and the output of energy. The intake of food may be altered by monitoring intake, restricting food, having only certain acceptable foods, or voluntary starvation. The output of energy may be altered by diet pills, laxatives, diuretics, binging and purging, or excessive exercise. The general risk factors associated with disordered eating and/or eating disorders include chronic dieting, low self-esteem, family dysfunction, physical and sexual abuse, biological factors, perfectionism, and a lack of nutritional knowledge. Athletic risk factors for disordered eating or eating disorders include an athletic personality, which is goal-oriented, perfectionism, compulsiveness, and is based on the ability to block distraction. Emphasis on body weight for performance may also be a factor. Pressure from coaches, parents, judges, and peers, overtraining or sudden increases in training, vulnerable times including injuries, win-at-all-cost attitudes, and this overall athletic personality. There are some very dangerous and harmful effects associated with eating disorders. This includes depletion of muscle glycogen stores, dehydration and electrolyte abnormalities, loss of muscle mass, hypoglycemia, anemia, amenorrhea, and osteoporosis, to name a few. Again, we've talked a lot about female involvement with eating disorders. However, men are also likely to suffer from disordered eating or eating disorders. Unfortunately, men are less likely to seek treatment for eating disorders because of the perception that this is a woman's disease. There is also a social stigma that is associated with this kind of disorder. Osteoporosis is either premature bone loss or inadequate bone formation. Risk of osteoporosis is associated with the length and severity of menstrual irregularities, nutritional status, type of previous skeletal loading, genetics, and possible medications. 60% peak bone mass is achieved during adolescence. Bone mass increases 45 to 60% in the second decade of life. We have peak bone mass by the third decade of life, or in our 30s. We have a premenopausal bone loss of about 0.3 to 0.5% per year. Once we're in menopause, bone loss increases to about 3% per year for the first 10 years. Osteoporosis is characterized by general bone loss throughout the skeleton. We are at an increased risk for stress fracture. There's also an increased risk for premature osteoporosis based on the female athlete triad. There is some question as to whether osteoporosis is reversible. Some new research has suggested with the proper medication, nutrition, and skeletal muscle loading that some of the effects of osteoporosis may be slightly reversible. Treatment for eating disorders in the female athlete triad include recognition and early treatment, education of young athletes, supportive and confidential environments, approach the athlete as injured, lower performance expectations. Lower expectations might mitigate against guilt and disappointment in poor performance. Poor performance is eventually seen with eating disorders and disordered eating. Prevention of eating disorders should include education of both our coaches and our athletes, nutrition and weight control, dispelling myths, and screening processes. We need to provide non-threatening locations to obtain assistance.